Well, hello. I want to welcome you all. My name is Ari Olumi from Beth Israel Deaconess Medical Center, Harvard Medical School, and Chief of Urologic Surgery at Beth Israel Deaconess Medical Center. I want to welcome all of you to this webinar, an exciting one focusing on physician scientists and different paths to success. Before introducing the panel, I want to give a special thanks to Shelby Englert and all of our AUA staff members who've made this webinar possible, and also special thanks to the Research Education Conference and Communication Committee that has been led by Dr. Margot Damisser, who've had significant input in bringing this topic forward. The objective of our webinar tonight is to highlight the diverse experience of our panelists and also showcase the multiple career trajectories that are available to physician scientists in urology. And we hope to explore challenges, opportunities, and key decision paths that have shaped their paths and made them who they are today. So without further ado, I'd like to spend a few minutes to introduce our panelists. We have 4 panelists today, and we've attempted to have panelists from different backgrounds and different trajectory paths to different areas of success as physician scientists. First is Dr. Christopher Barbieri. He is the Sacerdote Distinguished Associate Professor in Urologic Oncology at Weill Cornell School of Medicine. He is a nationally recognized surgeon scientist, and he is known for his pioneering work in prostate cancer genomics. He has received multiple extramural awards, including multiple NIH R01 grants, Damon Runyon Clinical Investigator Award, and the Prostate Cancer Foundation Challenge Award, and has published extensively in top journals like Nature and Cell. And he's a frequent invited speaker at national and international meetings and has been honored with the AUA Rising Star Award and the SUO Young Investigator Award. Welcome, Dr. Barbieri. Next, we have Dr. Rose Kovari. She is a professor of urology at Houston Methodist Hospital. She is nationally recognized as a leader in female pelvic medicine and reconstructive surgery. She is known for her translational research in neurourology and neuromodulation. She has received continuous NIH R01 funding and served as principal investigator on numerous clinical trials, leads interdisciplinary team that bridge clinical trials and imaging and brain spinal stimulation. And she has started the urology program the residency program at Houston Methodist in 2016 and brought it to new heights, and has served as a program director for the last decade. A passionate mentor and educator, she plays a central role in training the next generation of physician scientists in urology. Welcome, Dr. Kovari. Next, we have Dr. Peter Sholem, a visionary leader in academic medicine and biomedical innovation. Dr. Sholem previously served as chair of urology at Yale and chief innovation and transformation officer for Yale New Haven Health System, where he helped launch major interdisciplinary programs in biomedical engineering and clinical innovation. He is now the chief scientific officer for Johnson & Johnson MedTech, where he leads the global scientific strategy and collaboration at that institution. He is a trained physician scientist and urologic oncologist, and Dr. Sholem is widely recognized for his pioneering work in minimally invasive surgery and translational technology. And please join me in welcoming Dr. Sholem as one of our panelists. And finally, we have Dr. Neil Shore. It's my pleasure to introduce Dr. Shore, who is the medical director of START Carolina's Carolina Urologic Research Center and director of the GU Oncology Center of the Excellence at START Oncology, a global leader in early phase cancer research. He has served as principal investigator on over 400 clinical trials in prostate, bladder, and kidney cancer, and has authored more than 500 peer-reviewed publications, including multiple first and senior author papers in the New England Journal of Medicine that have helped shape clinical practice. A past president and founding member of LUGPA, the Large Urology Group Practice Association, he's a national leader in translating innovation into real-world oncology care. I'd like to welcome all of you panel members. Thank you for your time that you've put into this program. And first off, I'd like to start off by opening our webinar by posing a question to our 2 panelists, Drs. Barbieri and Dr. Sholem. In my role as the chair of the Research Council at the AUA between 2015 and 2021, one of the biggest initiatives that I tried to bring forward was the type of training that our physicians get in research is not often adequate enough for them to sort of advance in a meaningful manner. Both of you have dual degrees as MD and PhDs. Maybe you can share with us why you sort of chose that path to obtain an MD PhD and how that has helped shape your career. Chris, we'll start off with you, please.
Yeah, absolutely. Thank you. Thank you for having me here, and thanks for the question. I mean, my decision to pursue a dual degree was kind of a very classic reason that I was interested in science, throughout college and afterwards, and I realized that the research and the science I was interested in was essentially biomedical research. And it made perfect sense to me to pursue training that allowed me to have interactions with patients and do research that impacted patients' lives. So that was sort of a very natural sort of, I was one of those people that sort of couldn't quite decide which route might be best for me, and sort of both seemed like a way to strike a balance between them.
Great. Peter, how about you?
Ari, thank you very much for having me, and thank you for this opportunity. When I was back in college, I was very much interested in organic chemistry, and I wanted to get a PhD in organic chemistry. And then I heard of this MD PhD program where I can combine both the basic science and a medical education. So I was fortunate enough to get into the MSTP program at Baylor College of Medicine. And I think in retrospect, of course, when you're young, signing up for an 8-year program, which it was for me, you don't even think about it. Now, several years later, you go, I actually did 8 years just to get to that point. I tell everyone I was like the only 30-year-old at Hopkins in a short white coat and white pants who looked like an ice cream man at the age of 30. But it was an amazing opportunity because what I realized is it taught me a way of thinking that I would not have gained otherwise. Medical school to me is it's more of like learning a language. Residency is really a practice of medicine, but my PhD really gave me an understanding of scientific thought. And despite the fact that I thought, my PhD is in immunology, I thought I was going to be either a transplant surgeon or a medical oncologist with a wet lab, fell in love with surgery. And interestingly enough, I'm a little bit different than most because I followed a path of innovation, but I think my PhD really helped me during my career journey in better executing on innovation around med device. So, I think early on, I tell everyone you want to be more divergent than convergent. So you should take on opportunities that open your aperture, not close them, because eventually you have to restrict what you're doing. But to me, getting the MD PhD just opened more doors for me at that time.
So it sounds like that additional training specifically focused, whether it's obtaining an official PhD degree or that additional training may have had a significant role in your success as a physician scientist throughout your career.
Absolutely.
Rose, you mentioned yourself that you consider yourself as a late bloomer. You've sort of traveled a different path than most physician scientists. Maybe you can share that experience with the group.
Of course. Thank you so much, Arya, for having me on this panel. It's really a delight to be here with Chris, Peter, and Neil. So, Peter, actually, just a shout out to you. Today, I was talking to Brian Miles and Tim Boone, and they're like, "Oh yeah, we remember him from the Baylor days." So, good to see you here. Yes, so I actually did a year of research, part of the residency at Baylor with Dory Lamb. So I got introduced to more infertility kind of research, but I never had done any formal training like a PhD or like any fellowship in clinical trials or any outcome research or anything like that. Everything was just like retrospective studies, case reports, those sort of things that a lot of the residents do nowadays, and they did back then as well. And it really never occurred to me that I can follow the path of research or I can really contribute or make an impact in it until I became a fellow myself. And towards the end of it, when I participated in a project with Sophie Fletcher on neuroimaging and brain bladder control, I was actually the very first subject in the MRI scanner with the urodynamics testing. That sort of sparked my attention to this kind of research, which it was brand new to me. And then later on, as a junior faculty, that mentorship that I had with Tim Boone just kind of pushed me, challenged me, made me apply for K-12 that Dory had, and then the rest K-23, and then the rest were the other grants that came afterwards. But I think the key point for me was that I never saw myself on this path until I was a junior faculty, and I had the support, I had the encouragement, and then it just all worked out, and I learned throughout. So you were 30 when you were running with the short code. I think I was 30. I was just learning how to do statistics. So it's never late.
So it sounds like the passion, also the additional training, plus being in an appropriate nurturing environment that may have had an important role. Neil, maybe I'll ask you next. You've built a nationally recognized clinical trial center in a private practice setting. How did that vision begin, and what lessons can academic centers learn from your success in carrying out industry-sponsored research programs?
Well, I love the question, but if it's okay, I just wanted, I love hearing everyone's journey. I wasn't even sure I was going to go to medical school, and I was going by a bulletin board, and where there was you tear the things off, and I was a sophomore in my first semester at Duke, and I saw a friend, and she caught my attention, and what this was a foundation being sponsored by the Rockefeller Foundation, and offering early admission, early acceptance, not admission, to Duke Medical School as a first semester sophomore. And you would matriculate as you normally would. You wouldn't cut short your 4 years. And so it allowed me to do the bare minimum of pre-medical obligation. I double majored in U.S. history and public policy, health policy. And it was kind of fascinating because I wasn't really interested in doing any research. I learned certain phrases like survivor guilt. How did we get in when other people didn't? But so I go to med school, and all I wanted to do after doing a summer clerkship at MD Anderson was, do cystectomies and neobladders. I mean, that was it. I just thought if I could just do that all day long, that would be nirvana. And I went off to residency at Cornell at New York Hospital, which is now Weill Cornell, New York Presbyterian. And all I wanted to do was operate. I was across the street with, Willett Whitmore and Harry Herr, and Daracot Vaughn was our chairman. And all I wanted to do was operate. And I was not interested in research. And then I got out into practice, and about 5 or 6 years into it, so now I'm in my late 30s. And I suddenly, a spark went off, and I recognized, and this was in the 90s, that, gosh, other than doing all these great surgeries, there were all these unmet needs. And we had really nothing in geo-oncology for patients who we weren't curing with surgery. And it was pre-internet. And I started, talking to people in industry and saying, well, how can I help out? And they're like, well, you can't help out. You're not in an academic center. But I said, but I have all these patients, and they were not offering them much of anything. So that really was the spark for me, and seeing this enormous unmet need, and how I could help, the major medical centers by helping to get more involved in clinical studies. And it wasn't always easy, because, it didn't have the gravitas of being at a Mayo Clinic or an MD Anderson or a Sloan Kettering or a Baylor. But ultimately, I think folks got to see that, we could do the work, and we could accrue with quality, and we could help in the process. And so I think of the great Robert Frost, Robert Frost line is, taking the road less traveled, and doing it in my late 30s. So I hope for anyone listening, there's always, and I think all of our colleagues sort of had similar experiences. So anyway, getting back to industry, you have to prove yourself. You have to quality, and putting together a team to demonstrate to both industry, and I've done a fair number of NCI and NIH programs as well, but you've got to produce, and you've got to have a real dedication to it. You can't dabble in it. It can't be a dalliance. But just one final thought on your comments earlier, question. Mentors really matter. I mean, mentors are huge. And I think back in the wonderful mentors that I have, now 25, 30 years ago, who I still think about today.
Great. And then what do you think, for example, academic centers can learn from the successes that you've had in sort of large urology practice groups to conduct these types of clinical trials?
Well, the one thing we always hear is, 20% of the oncology is taking place in wonderful, phenomenal tertiary academic centers. The other 80% is happening in the community. It's always been my message to the SUO and to AUA and to our medical oncology, radiation oncology colleagues. This is not internecine warfare. This is not an issue of subspecialization turf. It's always about putting together multidisciplinary excellence so that patients optimize their care, right? That's the North Star, is patient care. And so I think the thing for academic centers as well as communities to recognize, we do much better when we work collaboratively and collegially. There's this huge person power shortage, graying of the world, lots of oncology. And I still look at the data that shows that patients are not getting optimized care. So working collaboratively, that's the key aspect. The challenge for academic centers is they have, more bureaucracy and more regulatory burden. And so the community centers that are able to do it well, they can start up faster. But I'm worried about that, frankly, right now with some of the cutbacks in support to academic medical centers. Because let's face it, our best and brightest are usually in the academic medical centers, and we have to continue to support those efforts.
Wonderful. Thank you. So the next question I'm going to pose to Peter, what factors influenced your decision to leave a prestigious academic role and join J&J, and how does the innovation process differ in the corporate versus the academic world? And for someone who may be interested as a physician scientist, how best can they position themselves to either collaborate with industry or transition into industry?
Okay, so a three-part question there. All right, you're testing my memory now, so I'm gonna have to say, so why, what's the difference, and how can one get in? I will tell you, so for me, I was not looking for this path. As you know, I was at UCLA, then at Yale. I started two institutes, both on medical device design, CBIT at Yale, and then CASIT at UCLA. Both of them very similar. CASIT was more about education. CBIT was more about acceleration and incubation of ideas that were meeting unmet needs. And I had a great position at Yale, and was also was interim chair or interim director of the Cancer Center, and I had the role of chief innovation transformation officer. I also did a lot of work with tech transfer. And J&J called out of the blue about 5.5 years ago and just said, "Are you interested in a job?" And I laughed at first. And then I thought about it, and I realized my passion, my whole career has been around medical device design. And I never thought that my passion in medicine, which was kind of a hobby, could become a profession for the latter. As I tell everyone, I'm on the back nine of life here. So gives me the opportunity to do something differently. So it was completely unexpected. I also realized, and this is what I tell most, because I was asked this question by everyone when I joined J&J, I felt as though I was beginning to feel too comfortable. I had hired great people. I had an amazing opportunity at Yale, but I had built an incredible group of colleagues that really did the majority of the work. And every day, I think I used to say, whether I went in or not, I knew I was going to, everything would be fine. And I said, is this it? Or should I go ahead and put myself into an uncomfortable position again? Because jumping into industry is definitely that. I can tell you it's now 5 years later, 5 years in August of this year. August of this year will be 5 years. I have not regretted a minute of it. I did it because I think it was an opportunity I didn't see coming. I was feeling too comfortable, and I wanted to feel uncomfortable again. And I tell everyone I'm 100% successful. I'm uncomfortable, very uncomfortable, learning a lot, and it's amazing. So I would say that's the journey why. When you say what's the difference in innovation, when you're in, running these centers around that are accelerators and incubators, you really focus on the technical aspect. We're all clinicians. You see an unmet need, you want to have a solution, and we learn how to build out that proof of concept around that solution. And I've written papers on this with respect to this, how do you accelerate academic innovation, and you need to focus on the clinical, the technical, the business, and the regulatory. But I knew that, but when I went to industry, I really did not understand or appreciate the level of work it takes to bring a product to market and to keep it on market. And I would say that's the greatest difference. You underestimate what is needed to create a safe product that actually has a reasonable gross margin that is compliant with all the regulatory responsibilities. And I tell everyone, I said, when I was a resident and an attending, I couldn't understand why a stapler would be $600. Now I can't believe a stapler is just $600 based on the amount of work it takes to get it to market. And then the final question really goes around, how do you prepare yourself to work with industry? Well, I think Neil said it best. So industry need academia. I tell everyone, academia needs industry, industry needs academia. And it's a flywheel effect. And just as I mentioned, like on innovation, the unmet need, the technical aspects come from academia, but how do you actually scale that and commercialize that? That comes from industry. So I tell everyone, because people ask me, how do I get your job? Well, I tell people I wasn't looking for my job, but what I've learned is, number one, having some exposure to industry early on is helpful so they understand how it works. Clinical trials, like Neil does, is a perfect example. Number two, I tell people your greatest benefit to industry is as a clinician. So you shouldn't even think about going into industry until you've been actually practicing for a minimum of 10 years post your fellowship, because that's the greatest value. There are a lot of people I meet who are physicians, but they've never practiced. Your greatest value is what you bring to industry as a clinician. And then third, I said leadership is incredibly important. The first thing they asked me at J&J is, okay, how many people have reporting into you? Because J&J is 140,000 employees globally. We have 70,000 alone in med tech, and they're interested in leadership. So I tell everyone, do whatever you can to gain leadership experience through positions either in academia and in the private sector, working with your hospital. But those are the things that are incredibly important if you'd like to transition or work with industry. Thanks, Ari.
So collaboration, maintain your clinical acuity and activities. One of the questions in the chat is, when may be the best time to transition if one is interested as a junior faculty member, mid-career, or later in your career? And it sounds like there may be an opportunity at any of those.
I think it's more 10 years experience. And the other piece that's interesting that I think is good is if you're thinking about industry, whether it be on the innovative medicine side or on the med tech side, understanding the regulatory processes. So starting to educate yourself on what this environment is all about is also very helpful. But again, first and foremost, become a surgeon or a physician. Do that well. And while you're doing that, gain the experience and exposure you want to industry. And then at some point in time, and I just hired Africa Wallace just 1 year ago. She's a cardiothoracic surgeon who trained at Pitt not Pitt, UPMC. And she's fantastic. And she was literally at her 10-year mark, and she wasn't sure she wanted to come over. I convinced her, and for better or worse, and she's fantastic. She's been now with us 1 year and loves the position.
Thank you. Chris, let me ask you this next question. You've maintained a very highly successful basic science lab focused on prostate cancer genomics. What are some of the biggest challenges in transitioning from a post-training time, whether it's residency or fellowship, to an R1 funded independence?
Yeah, I think that transition's tough for everybody. I think the biggest thing is that you're going from a trainee and you have to learn how to manage a small business, basically. And it's not something you're trained in any way, shape, or form, sort of to run a lab and to run that as a business, basically. So, it's the aspects of, hiring people, project management, firing people when necessary, recruitment and retention of people into your lab. that was definitely the biggest thing I had to sort of learn how to do, and learn how to do by making mistakes, definitely. The fact is that when you're running a research group or running a project even, you're completely dependent on your team, basically. Like, your career is in their hands to a large degree. So, having those people, getting the people in place that you trust and that how to motivate and and do a good job. Knowing when that's not working out and when it's time to sort of pull the plug and say, okay, it's time to like move on and with something else. Understanding that the ideas of sort of, what are you looking for in people on your team? I think I made the mistake early on of thinking I was going to hire for skills, like that there were, specific tools in the toolbox that I was sort of looking for and looking to fill those types of positions. And I think I realize now that you can teach skills to anybody if they are smart and motivated and care about doing a good job, basically. You can't teach that. You can't teach somebody to care about their job and want to do a good job. So, that aspect of sort of what you're looking for in your team is something that definitely was a big learning process for me, and definitely luckily has worked out relatively well.
Great. Well, thank you for that. Rose, I'll pose the next question to you, but we have a couple of questions that are coming up in the chat. I'm aware of them, and I'll make sure to bring them up. But Rose, you have worked and integrated well in a multidisciplinary manner between neuroimaging, neuromodulation, urology. What has sort of sparked your interdisciplinary vision, and how has that played into your success?
So, Arya, I really think in my case, this went from the bedside to the bench, and actually in this case to the MRI core. And as a PGY2, being in Tim Boone's clinic, and seeing all this neurogenic bladder patients, augments, all these amazing surgeries that we do, but still to a point, there's like a ceiling to it. There was so much that we can help them. And then later on, when I started specifically for like the MS patients, that the only thing that we could offer them for bladder emptying problems in this day and age, in 21st century, was a bag of catheters. These patients would come in, young ladies having difficulty voiding, urinating, and all I had to give them was a bag of catheters and say, pick the one that you want, and guess what? There's 20 different kinds in the bag. But we had so many medications, onabotulinum toxin, injection, sacral neuromodulation for the storage phase, and nothing in the voiding phase. Seeing these gaps in my own practice and the practice of our mentors made me feel like we need to do better. We need to look at this a little bit more. And you can't do it alone. I mean, this is a field that I had no experience in. And as urologists, we won't be able to move it forward. I think everybody touched on it. We need to collaborate. Like with my field of neuromodulations and neuroimaging and learning about pathways, I need physicists on my team. I need neuroimaging experts. I need neurosurgeons, neurologists, engineers. I work with a lot of engineers on my team. So I think that collaboration, bring them all together, and then me as a clinician, as a urologist, posing my question, and then getting the help that I need to create a study, to create a trial, to help answer that question. So a lot of people on my team really has helped develop the lab that we have right now. I think we're talking about a little bit about our personal paths as well. I think I need to give a shout out to my husband as well. He's a neurosurgeon, actually brain tumor, so he does oncology, but he comes from a really very traditional MD PhD path and all of that. So very, very scientific mind, totally opposite of me. For me, it's like there's a question, come up with the answer, like a surgeon mind. So running these ideas at the beginning, and it was, again, totally out of my field. Like neuroimaging, I had to review all the anatomy, atlases, running it by him, by individuals like him who could give me feedback and kind of make sure that I am not totally daydreaming about ideas, were really helpful. So again, I think in any field that we want to move forward within our urology world, specifically these niches, we'll really need to look outside and bring in expertise and collaborate.
So again, collaboration, multidisciplinary team seems to be a recurring theme. Neil, I'll pose the next question to you. What advice would you have for a resident or fellow who may be considering a physician scientist career outside of academia?
Well, I just love this title of our program today, physician scientists. I've often thought to myself, if I were on a medical school admissions committee and there was an applicant and I said, well, what are your thoughts about being a physician scientist and about research? And if he or she said, oh, I'm not interested. I just want to be a doctor. I would immediately, that application would be in the no-go. And there's all spectrum of being a physician scientist, but we're all physician scientists. Some of, obviously great folks on this symposium, this panel here. But if you go into medicine, it's really part of our DNA and our core. You have to be thinking about how we're going to change healthcare, and all the time. So I think that for for medical students and residents, it's recognizing that the importance of that. Was it Halstead who said the wards are laboratories of the highest order? And that's how we make advances. That's how we, help cure HIV/AIDS. It's how we advance cardiovascular care. It's how the number of advances in geo-oncology is astounding in my career. So I think it's remarkably important for medical students, residents, fellows to really become passionate and engaged. You hear this comment, if you want to get something done, give it to the busiest person in the room. There's a lot to be said for that. Is the people be productive, and if you're productive, it also will allow you sort of that on-the-job training. I appreciate what Chris said about this. I didn't have any business administrative training on any of that. I had to learn, and that's okay. You'll make mistakes. Don't be afraid to make mistakes, but just keep working hard at it, and you will be successful.
So I'll follow up on that to address one of the questions in the chat. I'll pose that to Peter. The question is, what are the pros and cons to keep working clinically while working for industry, and is it possible?
Well, first off, anything is possible. The question is, what's best for you and how do you make that work? And I think I will tell you at J&J, for me, being a surgeon and then becoming a full-time, chief scientific officer, that would be very challenging. I felt as though I would do a disservice to the patients. And for me, at the time that I made the decision to go to industry, I also chose not to practice anymore. Now, having said that, there are physicians at J&J who practice, but some of them are critical care, for instance. So it's easy for them to step in and step out. I think it's very difficult to step in and step out as a surgeon. So I had, as I mentioned, Africa earlier, I had that conversation with them, and I said, I think it's very hard to be a cardiothoracic surgeon full-time at J&J. Could you do part-time? And I think those are options that are available. And that part-time can range, if you look at Neil works quite often with industry, and it's actually his clinical practice that allows him to do the clinical trials he's doing. So, to me, it's a spectrum. It's either all in one way or all in the other, and then everything in between works. I will tell you that I have mentored some in the last several years who are thinking about the transition. And I tell them, instead of jumping in with both feet, just dip a toe in the water and, see if you can work with industry, and then maybe get a 1 day a week kind of arrangement so that you can see how it goes. And then after a year or so, you can progress from there. It also gives you the chance to see what it's like as you decrease your clinical volume. It's interesting. We're all surgeons, and sometimes we only define ourselves as surgeons, so it's very hard to walk away. We've all had those mentors who go until they're, it's forever. I think it's good to find another path. I've learned a lot, and I'm now getting to, I tell everyone, this is not a new chapter in my life. This is a new book in my life. And it's a unique opportunity to take the experiences that I've had up to this point and bring them into another industry.
Great, thank you. And you personally yourself, I don't think you're practicing clinically actively right now. Is that correct?
I stepped away 5 years ago,
Okay.
did my last donor nephrectomy, and walked out the door.
Okay, very good. But we do have examples of individuals in that spectrum, as you mentioned.
Spectrum, yep, yes, sir. Yep.
Chris, I'll pose the next question to you. What do you know about mentorship, sort of giving and receiving, and things that you may wish you knew earlier in your career? If you had to sort of go back and sort of do it over again, how would you do it, and what kind of advice would you give to individuals at this point?
Yeah, I think in terms of mentorship, I think the biggest thing I've learned over time is, there's no one mentor that can provide everything that a mentee sort of needs, that can sort of check all the boxes and sort of provide all the advice and all the mentorship and all the sponsorship and all the advantages. Everyone needs a team of mentors, and everyone needs a network, and you have to be active, and you have to be aggressive about pursuing some of the mentorship and advice that you can get from a group of people, to build those connections and to use those connections to help yourself, to help your career, to help learn how to do things differently, build your skill set, because that's a lot of how opportunities come. The more sort of doors you have open to a variety of people, the more chances you have for something to sort of walk through one of those doors that's really an incredible opportunity and that you can do a lot with. And it's also the situation where if you're embedded in a professional network like that, as a mentee, if you have a scientific project of a certain type, when something interesting comes up with that, you kind of already know who to call to get advice about that specific thing scientifically, or who to call to get advice about that job you're looking at on a different coast that you're not familiar with. And that's a huge advantage.
Great. Well, thank you for that. I want to shift the topics a little bit. Before I do that, I encourage the audience to pose any questions you may have in the chat, and we'll try to get to them. But the next question I want to pose, Neil, is to you. As I've sort of grown through my career, I've sort of learned to appreciate the power and the need for advocacy and working closely with the federal government. You've been involved in LUCPA, AUA policy. In your view, how do you think advocacy and research intersect in your work currently?
Oh boy, now more than ever. And I think the advocacy to establish dedication of resources, regardless of whether it's in community or in academia or at the federal or state level, and it should be interdisciplinary, and it should be integrated. But I think it speaks to the importance, as we're all scientists and we're so proud of it, and we battle and debate and we give contrarian viewpoints, but we do it in a way that is respectful, and it's based on evidence. It's not based on hearsay. It's not based on some invalidated opinion. And so to me, I think right now, more than ever, the importance of scientific rigor and credible voices to establish authenticity. There's a lack of trust right now amongst the population. Clearly, we see it in our patients who come in all the time wanting kind of crazy concoctions because they read something on Facebook with someone who didn't have any sort of scientific gravitas. And actually, even saying scientific gravitas or authenticity sometimes turns people off. So I really think we are at a critical inflection point to really establish physician scientists and the credibility that's always been there, but it's suddenly under assault. So advocacy, whether it's the large urology group practice association, which is now working very well together with AUA, with SUO, with ASCO, and we work internationally now. Everyone, right? It's ESMO and EAU. We're all in this together, and I think that's why we have guidelines. It's why we have debates. We have these wonderful events, and that's really where hopefully patients are going to get the best information. It's a challenge right now, right? We all see this in our clinics every day.
Great. Thank you so much for that. We have two questions from two students, both are MSTP students in the chat, and they're wondering how, for example, do you balance your research activities with your surgical clinical practices, residency, fellowship, and so forth? Chris, maybe I'll pose that to you since you've been through that MSTP program, both you and Peter. But maybe you can sort of answer that for our students who are on the line.
Yeah, so in terms of, my current sort of day to day and how I balance, I operate 1 day a week. I see patients in the office 1 day a week, and then I have 3 days that is sort of carved out for research time. Clinical time is always sort of greedy and sort of seems to expand and try to claim more of itself. But that's a pretty good balance for me, and I like that. I think for me, I think just like Dr. Shulam was saying, the clinical time is really valuable. I mean, the fact is what I like to do and what I do is I like to think about the biology of prostate cancer. And the biology of that disease is in our patients. That's where it manifests itself. It's not, cells in a dish. It's not the mouse models, which I use a lot of. What matters is what's going on in our human patients. That's what we're trying to learn about. So seeing those patients and working with them is, I think, where we learn the most and where it frames sort of what we do in the lab to try to learn what's going on in that patient, basically. So I think it's critically important and it's critically valuable to do both, because I think as surgeons or as active clinicians, I think we have the opportunity to sort of be the true experts in the biology of the disease from top to bottom, which is, like I said, incredibly valuable in terms of leading a research team that focuses on that.
Great, thank you. We have a question in the chat from an individual who's a Brazilian urologist starting a 1-year research program at UCSD. While waiting for diploma validation, how can he or she excel in the research project? Rose, would you mind taking that question? What do you think?
Sure. I'm actually going to make a few more comments we're talking about trainees and mentorship and medical students. I like the fact that I totally agree with Dr. Shore that we all have this curious mind. We're all a little bit of surgeon scientists or physician scientists deep down. So if a medical student or if a student does not agree with that, maybe medicine is not the path for them. And the same carries over to the residency and then the rest of the training program like fellowship. So I wear the hat of the residency program director as well. And I think we are in a really, really exciting time because we have this opportunity to incorporate a lot of these resources that AUA has put together and are available in the training of our residents. For instance, we always say that you need to see one to be inspired to be one. And then programs like this that really showcased spectrum of physician scientists, other training AUA core curriculums that are focused on research training, they need to be part of our residency training from the very, very early on, because not only they may not want to necessarily do clinical trials, but they need to be able to understand and read a clinical trial and be able to use that data for their patients. So if they can't understand the limitation of a trial that they're reading, then they can't offer good care for their patients. So I think we're really in the right time with the resources that I think since you were part of the AUA, research committee, putting together all these initiatives and programs, it's really, really helpful. Now, aside from that, there are other programs that are becoming into light. I don't know if you guys have heard of like NMED program, which is training physician years. So this is an A&M program with Houston Methodist Medical School. So we bring in engineers, and then they graduate with a master's in engineering and a physician and an MD degree. So they're from very early on. They start different projects. They work with a lot of clinicians, and they graduate as physician years, very familiar with how to take a concept to commercialize it, how to patent an idea, how to really create a design. So these smaller programs, I think we're hearing more and more of them because of the resources that we have, because of the programs like this that we have. So So I think as educators and mentors and chairs and people here on this panel, we really need to look for those individuals in medical school or residency and really foster them, sponsor them, mentor them to either become the full-fledged physician scientist or just learn how to use these skills in their own practice on a day-to-day basis. Specifically for that individual's question about how to really orient themselves and get the most out of it during that 1 year, I think you're in the right place. The most important thing is to have a group of mentors. And that was mentioned here multiple times, not just one person. Really expand your mentorship team and have not everyone needs to be a mentor or have a mentor, but advisors. Make sure you connect with people, have advisors that you can do different projects. So you're not invested in one thing. So that 1 year can be fruitful at the end of it from the research standpoint. Write as much as you can, attend meetings as much as you can, present, use any opportunity given, even if it's in a lab next to you and you think you can contribute to it, just pick that opportunity and utilize it. And a year goes by really fast.
Great, thank you. Peter, I'll pose the next question to you. From your experience as being a chair, how do you think that departments in general can better support early career investigators with non-traditional paths in your view?
No, that's great. I saw this as a question earlier on, and I'm glad this is being asked because when I went to Yale and I started the institute, as you can imagine, Yale's incredibly conventional. And, my argument there was there are many ways to have impact on patient lives. And being a basic researcher and understanding mechanisms of disease and publishing in high impact journals, that's one way, but that's not the only way. And if you are creative and you're inquisitive and you're innovative and you're entrepreneurial and you see an opportunity while taking care of patients, and that leads to either IP or to the formation of a company, and it can have incredible impact on a patient or patients' lives, I think that's just as valuable. And we were able slowly to change the promotions committee at Yale to consider other ways of promotion other than publication, number of publications or impact factor, and that, IP works, companies work, all those are they're non-conventional. And think about the future of where we're going in these converging technologies. Life is changing and how we care for patients is changing. Digital, AI, ML, all this is going to have a huge impact and huge opportunity for all of us as physician scientists and caregivers to see opportunities of unmet needs that can be utilized or could be solved by the utilization of these converging technologies. And I think, it's unfortunate that it's taken a while for people to understand, because at the core essence of what we do and why we do it is to impact human life. And there's multiple ways to do that. So I just hope that people will begin to be more not so restrictive in the definition of what academic success looks like. And I will tell you, I came from Hopkins. When I took this job, I was afraid to call Dr. Walsh and tell him that I'm leaving academia, going into industry. But to his credit, he was incredibly complimentary. And I think, and I was at the time, Dr. DeKernian was my former chair at UCLA, and he called me as soon as he heard. So, I give credit to that guard that, recognizes the impact that you can have in various avenues.
Great. And then let's take that a step further, sort of reflecting on your own career. Well, where do you feel that you've had the greatest impact at the bench, in the OR, in the boardroom, in your current role at J&J, or all of the above?
No, every experience I've had, I've been incredibly fortunate. I tell people when I talk about my experience in my life, in retrospect, it looks like it was a straight line. It was not at all. So the storyline sounds great in retrospect, but prospectively, if you were living my life, I had all these failures that led to other opportunities. And I would say that everything in my life has informed everything else. So getting the PhD, ended up going to Hopkins for urology. I met Lou Cavussi, in the first, 1992, 1993. He had just done the first laparoscopic nephrectomy, got involved in computer motion, and I was really intrigued. Don Coffey took me out and said, what gives you passion? What gives you tachycardia? And I said, trying to understand how we can do something differently in the operating room than we have for the last 100 years. And that became my trajectory. So all I can tell you is I just feel fortunate in that I would say successes and failures are just as important.
Great. Well, thank you. So we have a question in the chat as far as from Ben Chu that they have an endourology fellowship. They're quite active in basic science and clinical research. What tips do you have to mentor trainees, and how much do we lead them versus teach them to soar on their own? Rose, you are a program director. You've been successful in the research arena with many grants. Maybe you could take that question.
Sure. I really like that comment that we learn so much from our failures than our successes. So I have actually a slide that shows how many grants I've written, and a good 90% of those did not get funded. So, and I learned from every one of them. So, and that's the thing. I think a lot of our trainees, especially in this day and age, the definition of mentorship, there's all sorts of definitions. And I think most of us went through the time that we just had the mentor without having it specifically defined mentor-mentee definition. And we had it different ways. There were people that pushed us, challenged us. I had Tim Boone that would write a little sticky on my desk and put it there, do this, and I would have to do it because it was my chair, as my mentor, I just did it. Or they would really hold our hand and walk us through it. So I think it's very individual trainee dependent, but what it's important, what I've learned, the hardest thing is that sometimes it may not work out. And those are the hardest conversations that I've had, either with a resident or a medical student, or I get a lot of other students. I get students who want to do radiology in my lab. I get a lot of actually undergrad engineering students as well. And sometimes it may not work. And that having that honest conversation that maybe this is not the right environment, maybe I'm not the right advisor for you, and we don't have to be specifically everybody's mentor that they want us to be, and helping them find another path, that is the key. This is something I learned from you, Arya. You've mentioned before how to learn how to pivot when the time is not right. So not only for us, but to also teach it to our trainees that if this is not the right place, if this is not the right environment or the project, or we're not the right team, they need to pivot and find something else that's best for them. But both ways, it's very, very dependent on the trainee. Some of them just need the minimum mentorship and they will run with it. They just need like touching base every once in a while. Some others, you hold their hands for a year and still nothing. It's just, and then that's the time to let go and learn. They can learn more from that sometimes.
Great, thank you. An hour flies by very fast. We only have 8 more minutes for our webinar. And this next question I want to pose to all of our panel members. So Neil, I'll start off with you. What are some of the most pivotal decisions or turning points in your career, and how did they shape your trajectory?
Yeah, that's a great question. For me, I was scheduled to do a fellowship with Jack Makinich as I was finishing my residency and starting my chief year. And unfortunately, my father passed away very suddenly, so I took a job in private practice. And instead of doing that and continuing into a role in academia, and then I didn't really like it. I was busy. I was operating, and it was a very wonderful place in New Jersey, great hospital. They had residents. It wasn't a good fit. And so met my wife now. We were engaged, and Bal Carter, my chief, he said, there's a guy down in South Carolina has been asking me to join him. Why don't you go take a look at this position? And, talk about the road less traveled. People thought this was crazy back in, 1994 to go from the New York area to South Carolina. And I did, because I figured this would be interesting. And so 35 years later, and about 10 years into it, after just operating all the time, I recognized that there were these incredible unmet needs in GU oncology, and companies were having a really hard time with their accruing, and that's what I decided to do. And so along the way, I think it's really important, of getting back to a comment Peter made, in community or in academia, we have different metrics of how we look at success. And that seems to change a lot. A lot of times in community, it's based upon your E&M and your RVUs and new patients visited and seen. And sometimes, you have to do things that are not necessarily quantifiable with data, but are really good for your organization and good for overall healthcare and for patients. That's true in academia too, right? And so I think that's very important to have leaders who recognize that. And just going back to the mentor thing, the one thing that I think is uniform in all mentors is mentors who have passion, and mentors like mentees who have passion. And if you have passion and you can demonstrate some level of mastery in what you're trying to accomplish, then that ultimately leads you to a lot of joy in what you're doing. And then you need to continue to then say to yourself, okay, I did that. So now what? What's next? And always have a sort of hunger to say, what's the next thing, and not rest on your laurels.
Great, thank you. Chris, I'll pose the same question to you. And if there's any specific examples of any failures that that may have sort of helped you sort of learn from that failure that have been pivotal in your
Oh,
career.
there have been failures. No, I think the pivotal thing for me was honestly my decision to go into urology after medical school. So I don't know if Peter's experience was the same, but I got advice that if I wanted to have a research career, that a surgical field was not viable almost, like, and not compatible with that essentially. And I sort of had the opinion that like, but I like being in the operating room and I like taking care of patients this way. So I will see how it goes because I have to be the one that gets up every morning and goes to a job. And if I'm, choose a field that is not fun for me, it doesn't matter if it's better for my eventual sort of like research career, it's still not a fit. And so I think that's the thing I can echo to a lot of the trainees. Like, I think a lot of times we sort of have a long-term goal, which is good to have, and think it's a very linear sort of ladder towards that long-term goal. And if you don't hit sort of the next rung correctly, that you're in trouble in some way, basically. I think you can be a little more flexible and do what you find is fun, sort of in the short term, and what you have passion for in the short term, and sort of let things fall and see how they work out, because maybe your goal will be different than it is, at that moment, and maybe it'll take you down a different path essentially. So I want to sort of convey that it's okay to sort of follow what you're interested in that day or that, year essentially, without thinking that is this derailing my sort of overall progression towards what I think might be a longer term goal.
Great, thank you, Chris. Peter, I'll pose that same question to you.
Sure. I'm just going to be quick. I'm going to touch on a few topics. One is mentorship, unbelievably important. I think of my mentors, Peter Scardino at Baylor. Then I had Dr. Coffey and Dr. Walsh at Hopkins. And I had Dr. Dukernian and at UCLA. And, Ben had asked a question about mentorship. And I will tell you, the one thing I learned from all of them is you lead by example. And I think that's the best advice I can give to anyone who is a mentor. I've already mentioned this, Dr. Coffey, follow your passion, do what gives you tachycardia. I think sometimes in life, we make it really complicated. We think about money, location, other aspects. And if you follow your passion, everything else will follow. I really believe that you do what you want. And I think just to underscore what Chris said, I meet so many mentees, they're thinking too far in the future. Just worry about day to day, and whatever comes your way and you follow that path, it will be the right path. And then just be comfortable being uncomfortable. Put yourself out there, because great things only happen when you're in that uncomfortable zone, not when you're comfortable.
Great, thank you, and Rose.
Sure. For me, I think I want to give a practical example. When I got introduced to the NIH community, like started with my K-12 and then moved on, just learning how to write and how to talk about my research, how to showcase the significance of it, the impact of it. I think that was a pivotal moment for me to learn how to really share what I'm passionate about with the rest of the world, with a group that can actually fund it. But during that journey, I got the K-12, I got the K-23, and a couple of little grants right the first time that I sent my application in. And then time came for R01. It did not get funded the first time, got rejected. Second time, rejected. I was so shocked. I was like, oh my God, I thought I knew how to write. And then the third time it worked out. So a lot of failures in this journey actually showed me how to share what I'm passionate about with sponsors. And now that has shown me to actually take my projects, take my passion to philanthropy. When I go talk to like people who are willing to sponsor our research on the philanthropy level, I can present it better. I can tell them why it's important. So I think for me was that NIH community involvement that I learned a lot from.
Wonderful. Thank you so much. Our time is up. It's right at the top of the hour. We do have a couple more questions. Marielle from the AUA office will circulate those questions. We'll get back to the individuals who've taken time to write the questions in the chat. I want to thank the panel members. It was a wonderful conversation. We could spend, I think, multiple days on this topic, and it's a challenging topic, and it's becoming more and more challenging with the environment of NIH and sort of the challenge that we have with the federal government and the academic institutions. And hopefully that won't turn off many of our sort of inspiring physician scientists. I think this is just sort of a blip in time. And I think, as multiple of our panelists have mentioned, if you're passionate about it, if it sort of gets you up in the morning and you're excited about it, and I would not sort of let sort of the current turn of events in politics turn you off from pursuing what really excites you and sort of gets you up in the morning to sort of contribute to the society, and as a result sort of have a fulfilled job satisfaction. So again, thank you all. I want to thank all of you for taking the time to participate in this. Thank the AUA, thank the REC, the AUA Office of Education, who put this webinar forward, and I think we had a very constructive webinar, and I appreciate all your time and efforts. Thank you guys. Have a good night.